the monitor erupts. The line goes wide, and fast, and chaotic. The rate near 200, no two beats alike. Your patient is slumped and unresponsible. You press 2 fingers to the carotid and hold. Nothing, no pulse. There is a defibrillator at the bedside, charged and ready. Everything now turns on what you do in the next 10 seconds. What is it? Here is your question. A monitored client suddenly becomes unresponsive. The rhythm is a wide, fast, disorganized complex, and there is no palpable pulse. A defibrillator is immediately available. Which action is the priority? A. Defibrillate immediately with an unsynchronized shock. B. Perform synchronized cardioversion. C. Give intravenous amiodarone. D. Continue CPR and defer the shock until the provider arrives. Pause and commit. 3, 2, 1. The answer is A. Defibrillate now, with an unsynchronized shock. This is a pulseless, shockable rhythm, either ventricular fibrillation or pulseless ventricular tachycardia, and the single most important thing you can do, the one that actually restarts an organized heartbeat, is to deliver that shock, fast. Every minute without it, the odds fall. The drugs and the rest of the code matter, but they come after the shock. Here is what is happening in the heart. An irritable ventricle, from ischemia, or a low potassium or scarred muscle, starts firing in a chaotic loop. The organized squeeze breaks down and the ventricles simply quiver. A quivering heart pumps no blood. So there is no pulse, no output, and the brain is starving within seconds. Only one thing interrupts that chaos and gives the heart a chance to reset, and that is the shock. So the whole decision turns on one question. Is there a pulse? With no pulse and a shockable rhythm, you defibrillate, an unsynchronized shock, delivered right away. But if that same wide, fast rhythm has a pulse, and the patient is unstable, you do not defibrillate, you cardiovert, a synchronized shock, timed to the R wave. Same looking rhythm, opposite shock. The pulse is what tells them apart. So here is the order. First, shock, defibrillate immediately, unsynchronized. Second, CPR, high quality, the moment the shock is delivered, hard and fast, with as few pauses as possible. Third, drugs and causes. Epinephrine every 3 to 5 minutes, amiodarone after the third shock, and hunt down the reversible causes, the H's and the T's. But the shock leads. Here is the rule to carry out of this. A pulseless shockable rhythm, with a defibrillator at hand, gets an unsynchronized shock, immediately, with high-quality CPR around it. And remember the divide. No pulse, you defibrillate. A pulse but unstable, you cardiovert. The pulse decides the shock. So, which rhythms do you shock? Only 2. Ventricular fibrillation, that chaotic line with no real complex. And pulseless, ventricular tachycardia, wide and fast with no pulse, those 2 get the shock. The other 2, arrest rhythms, asystole, a flat line, and PEA, do not. They get CPR and epinephrine, not a shock. And your pulse check should take no more than 10 seconds. So you never delay the shock the patient needs. 2 moves. Working together, the shock is the only thing that can stop the fibrillation and let an organized rhythm return. But a shock lands on a heart that has been starved of blood, so CPR is what keeps the brain and the heart alive, and primed, in between. One resets the rhythm, the other buys the time. You shock the instant the machine is charged, and you are back on the chest the instant it fires. Now 2 instincts that cost lives. First, reaching for the synchronized mode in a pulseless arrest. Synchronized cardioversion waits for an R wave to fire on, and in fibrillation there is no R wave, so the machine hunts and never discharges, and you lose precious seconds. In a pulseless arrest, the shock is unsynchronized. Second, shocking a rhythm that is not shockable. Asystole and PEA do not respond to a shock. Defibrillating them only interrupts the compressions that might actually save the patient. 2. To lock in. Which rhythms get the shock? The 2 V's, ventricular fibrillation and pulseless ventricular tachycardia. Asystole and PEA do not. And the deciding question, every time, the pulse. No pulse, you defibrillate, unsynchronized. A pulse but unstable, you cardiovert, synchronized. A pulse and stable, you slow down and reach for a drug, not a shock. The pulse picks the shock. Now the wrong answers. B. Synchronized cardioversion. It is a shock, so it feels right. But sync mode needs an R wave to fire on, and this rhythm has none, so it may never discharge. Cardioversion is for a pulse, not a pulseless arrest. That is the trap. C. Amiodarone. It is part of the code, but it comes after the shock, given during compressions, not before. And D. Deferring the shock until the provider arrives. In a shockable arrest, the shock is the thing that cannot wait. You are the one to deliver it, now. Tie it together. Your cues: an unresponsive patient, a wide, fast, chaotic rhythm near 200 and no pulse. Your action: defibrillate now, unsynchronized with high-quality CPR around the shocks, epi every 3 to 5 minutes, amiodarone after the 3rd shock, and a search for the reversible causes. And the outcomes you are steering toward: the chaotic rhythm reset, perfusion held up by good compressions, a pulse that returns, and the cause that started it treated. Now test yourself. Same wide, fast rhythm on the monitor. But this time, when you check, there is a pulse, and the patient is awake but crashing, a blood pressure of 80/40, gray and clammy. Do you defibrillate? No, there is a pulse, so this is not defibrillation, it is synchronized cardioversion, a shock, time to the R wave, and you sedate first if there is time. What changed was not the rhythm, it was the pulse. One more, you are running the code, and at the next rhythm check the monitor shows a flat line. Asystole. Someone reaches for the shock. Do you? No. Asystole is not a shockable rhythm. A shock does nothing but stop the compressions. Get right back on the chest, give epinephrine, and hunt for a reversible cause. Not every arrest gets a shock. This one gets CPR. One last patient. The same wide, fast ventricular tachycardia, but this patient is wide awake, talking, with a normal blood pressure and no chest pain. Stable. Do you shock? No. A stable patient with a pulse does not get shocked. You get a 12 lead, you reach for an antiarrhythmic like amiodarone, and you call for expert help, watching closely in case they slip. Stable buys you time, unstable or pulseless takes it away. Next episode. The opposite emergency. The rate does not race, it crashes, down to 30. The patient is gray, confused, and the pressure is failing. There is one drug you try first, and then the pads go on again. But this time not to shock, to pace. What are they? That is episode 12.